Our next step is to talk about, well, now we have a device in, how do we reduce not only the episodes of atrial fibrillation, but also the duration of the episodes of atrial fibrillation? And is that possible? Well, in this case, I think there's a lot of history behind this that we have to go through and talk about in order to understand where we are today. So there's been a lot of attempts in the past at suppression of atrial fibrillation using specific algorithms. So one particular algorithm is atrial overdrive pacing. And so atrial overdrive pacing is the simple idea that if you pace the atrium at a faster rate than the sinus rate, you'll be able to suppress atrial fibrillation. And there has been some data that's looked at this. For example, the Danish study and the CTOP study early on suggested that this was potentially reducing episodes of atrial fibrillation. However, more recently, in the ATTEST study and the ASSERT study, these types of algorithms were really not validated. Another way people have tried this is alternative site pacing. And so in this particular case, alternative site pacing simply means instead of pacing in the right atrial appendage, you might choose to pace in Bachman's bundle or in a different location. And some of the data early on also suggested that this type of pacing can reduce the time, increase the time to development of chronic Afib. However, again, when we've looked at meta-analyses and bigger data pools, it really has not validated that type of data. Lastly, dual site atrial pacing, meaning pacing in two different locations. Oftentimes we'll see, in the past, people putting in leads in the atrial appendage, leads near the coronary sinus, and pacing at the same time with the idea that that helps with atrial fibrillation. And you can see here, the studies show very small numbers, but did show initial benefit. But however, when you look at larger studies, really not the same amount of benefit that we had thought. Now, one area which I think is really, really interesting, and an area that I think in the EP lab at least we try all the time, is to try to overdrive pace in arrhythmia. And so there's a lot of history of overdrive pacing in our field. So the idea is, well, can you terminate atrial fibrillation with overdrive pacing? And the first generation ATP was developed for that reason. The first generation ATP was the AT500, and that was able to terminate atrial fibrillation up to 53% of the time. And so it showed a great deal of potential, at least early on. We felt that this was potentially going to change things. However, unfortunately, in the ATTEST study, despite 54% atrial tachycardia efficacy, it really didn't improve the atrial fibrillation burden. And a lot of these episodes probably would have stopped anyways.
Now, when I look through this on the historical attempts, I've been in the industry about 30 years now and have lived through a lot of these things and remember some of the excitement and some of the hope.
Yep.
Was there a little bit of hype potentially on part of industry that, we saw these results, we promoted it, and because as we go forward now into some maybe new algorithms, there's this feeling out there that those features don't work. Do you think there was a little bit of overzealousness?
I think all of us were overzealous at the time. I think everybody wanted to believe it, and I think all of us, wanted to have something to treat AFib. And so, again, I believe that all these historical attempts are actually important because they've paved the way to think about how to do it, how to try new things. I think we can't stop innovating. We can't stop thinking about ways to do this. Even though we failed in the past or we're not as successful, I think we need to continue to look for ways to innovate and improve.
And a question that came up earlier was on the first generation atrial ATP, where that looked to be a fairly high success rate. I think it was 53%.
Yeah.
General feeling on that was it was just coincidental?
Seems that way, but I will say occasionally we do see patients where it appears to be successful. So I think ATP does work. It's just, can you improve it?
ATP during AF or episodes when it's organized?
Well, we'll talk about that, yeah. So what's been successful? So let's think about what's been successful. Suppression of atrial fibrillation episodes. How can we reduce episodes, reduce the incidence and reduce the duration? Well, one thing that's been shown to do that is MVP, or reduced RV pacing. Now just remember, our MVP algorithm was really developed to reduce the amount of RV pacing because RV pacing all the time was found to be not helpful, hemodynamically not optimal. But it also turns out that, at least in the MOST study, every 1% increase of ventricular pacing was associated with a 1% increase in atrial fibrillation. And so when you add that to the idea of can we reduce ventricular pacing with algorithms such as MVP, now we're able to see, at least in the SAVE PACE study, that we are indeed able to reduce the episodes of atrial fibrillation, reduce the development of persistent atrial fibrillation in these patients.
So reduction of RV pacing was really about reducing incidence of heart failure.
Correct.
Coming out of the David trial, I believe.
Yes.
If it was correct. Kind of a link between those two?
I think so. And so I think it makes a lot of sense physiologically that you're able to improve the hemodynamics of the heart and therefore have less atrial fibrillation. So I think it ties in very nicely, and it makes a lot of sense that would work. Another method to do this is adaptive CRT, and this is another example where this is an algorithm that was really developed to improve the hemodynamics of CRT pacing, but the byproduct was that it decreased atrial fibrillation. So how does it work? So adaptive CRT really looks first at the rhythm, and then it evaluates the conduction, and depending upon the PR interval and the heart rate, it either does adaptive by V pacing or adaptive LV pacing, and continuously optimizes this every 60 seconds, with the idea that you can merge the left ventricular pacing with intrinsic conduction in order to improve hemodynamics. Mm-hmm. Now, what you see with this is a 12% improvement in CRT response at 6 months. And this is, when you get improvement in CRT pacing, you may also have improvement in all the other things that come with improving heart failure. So this is a study looking at patients who have adaptive CRT turned on versus conventional CRT. And you can see in the Kaplan-Meier curve, patients who have adaptive CRT turned on had a 46% reduction in atrial fibrillation risk compared to those who had conventional CRT turned on. Now, I will admit it's a post-hoc analysis with 474 patients, but it's important data and it's tantalizing data, and I think it makes sense physiologically as well.
And if I may point out, just for the audience, because we do different time periods, when we're looking at these, that this particular one then was for episodes of atrial fibrillation lasting greater than 48 hours.
Correct, yes. I think that's important. Now, when you look at real-world data, you see a similar type of trend. And so this is the CareLink database, and this is 44,000 plus patients who have the algorithm either turned on or off. And when you compare the two, what you see is a 35% reduction in atrial fibrillation risk when you have the algorithm turned on. And so this really confirms what we've seen in the same range of risk reduction as we saw with the previous study.
Mm-hmm. Now, this type of data we know has a lot of limitations. It's retrospective. We can't control for variables. In a practice like yours, does this have value to you, this type of information?
Yeah, I think it actually does. I think it's a large study, and I think we practice in the real world, and this is real world data. We don't practice in a clinical study. We sometimes wish we could practice in a clinical study, but the reality is that's not practical, and not all of our patients fit into a clinical study. Mm-hmm. What this really does is this validates that when you choose that algorithm to be turned on, as a physician, for the most part, you're helping your patients. Mm. So now let's spend some time talking about termination of atrial fibrillation using the newer reactive ATP algorithm. And so looking at this, we have to first look at the first generation ATP. And so this is an interval plot. And so you can see the ventricular beats as the circles and the atrial beats as the squares. This patient's clearly in atrial fibrillation. You can see all the intervals are all over the map. And basically you see is there's detection and then ATP is delivered. And I have to point out that there's occasionally more than one ATP delivered in these types of patients. And in fact, it didn't work in this particular patient. The patient remains in atrial fibrillation. Now, what the Medtronic engineers have figured out was that, hey, sometimes in these patients, we do see this clinically, sometimes in these patients, the rhythm seems to organize. And that may be an opportune time to go ahead and deliver ATP. And so when that rhythm organizes, you can see the squares are now much more aligned with each other. They're not as chaotic. Now if you deliver ATP, you're able to convert them back to normal sinus rhythm. And so that's what reactive ATP is.
Well, I'm certainly, you made a lot of Medtronic engineers very happy with the comments about their work, and obviously they did do a lot of work on this, but really the innovation, it really comes from collaboration with physicians and always has. Because what really happened here is our first generation of ATP stopped delivering at this point. And physicians such as yourself often brought forward episodes that said, later on, this patient's rhythm spontaneously slowed and organized, potentially could be terminated by ATP. We just didn't have any more therapy, and could we develop something different here? So it really, truly was collaborative efforts.
Yeah, I think that's important. I think having collaboration between physicians and industry is crucial and leads to very important innovations like this. So now if we look at the data behind this, this is the Minerva study, and you can look here, it compares patients who have DDD with reactive ATP plus the MVP algorithm on to patients who have the MVP algorithm on to control patients. And what you can see is there's a risk reduction in terms of atrial fibrillation in patients who have the reactive ATP on. In fact, a 48% relative risk reduction in episodes of AFib lasting greater than 7 days, a 52% risk reduction in terms of hospitalizations and ER visits, and I think one of the most important findings is fewer cardioversions, because I personally think that cardioversions, patients have to take a lot of time out of their lives to do it. It really does help those patients a lot.
Now, what might look like a contradiction. A few slides ago, you had shown that MVP was associated with a reduction in atrial fibrillation episodes. Yeah. And yet here, MVP looks no different from the control group.
Yeah, I'm glad you asked that. I think that's an important point. MVP in this case is in patients who already are known to have atrial fibrillation, whereas in the previous slide, those were patients that did not have AFib, so it simply reduce their likelihood of developing AFib, whereas these patients already have AFib, and in this case it's a little bit different.
So similar to adaptive CRT, MVP
That's
and
exactly
adaptive CRT their role, or their benefit has really been reducing the risk of AFib.
Reducing the risk of AFib, whereas this is really, once you have AFib, reducing the episodes and terminating the episodes. So now, again, it's important, I think, to look at real-world data, and so this is the CareLink data with this type of patient. And so here's 8,000 patients, about 4,000 in each group. These are matched, 4,000 patients receiving reactive ATP and 4,000 control. And when you look at it across all of these, whether they have atrial fibrillation for greater than 1 day, you get a 21% risk reduction, greater than 7 days, 40% risk reduction, and greater than 30 days, a 49% risk reduction. And those are the patients who generally don't convert. Those are the patients who just stay in persistent AFib. And so I think that's actually pretty nice to see that increased risk reduction in that patient population.
Now, does the larger benefit, moving from 1 day to 30 days, 21% to 49%, does that indicate that anything about the effectiveness of the therapy?
I think it does. I think it tells us that it's real. And again, I would tell you that we see this all the time. Patients who come in for cardioversion, and we'll say, hey, well, let me just try to pace them out before we put them to sleep. Many times we're able to convert them if their rhythm is organized. Similarly, we see this in our ablation patients, our pre-ablation, post-ablation patients all the time. We'll talk about that as well. Now, it's important, I think, to also understand that persistent atrial fibrillation may be a little different than paroxysmal atrial fibrillation in that there's a higher risk of stroke and an increased risk of death. These patients have a little bit more advanced disease. And so that matters, and having an algorithm that decreases the likelihood that they get persistent may be important. And this is a sub-study of the Minerva data, and I like this. This is very interesting and kind of tantalizing data. And so just to go through this, you see on one end control DDDR, in the center is the patients that received reactive ATP, and on the other side is the MVP arm. And the gray bar is unchanged left atrial size or diameter. The green bar is reduction in LA diameter, and red is an enlarged left atrial diameter. Now what's important to point out is the patients that did receive reactive ATP, they had reduced left atrial diameter as compared to the other two subsets of patients, and the likelihood that they would have an enlarged LA diameter was lower. And so it really indicates potentially that you're able to keep these patients from, remodeling their atrium if you're able to keep them in sinus rhythm more.
Very interesting data. I think we're going to take a little break here. There's a number of questions that have come in both during this event and from previous conversations about this. Questions about reactive ATP that seems to spark some interest. I think the first two I think you answered. Does it really work, and how do you pace terminate AFib?
Yeah, I think it really works. I think once the rhythm organizes, which we've seen in these patients, you're able to pace terminate them at a pretty reasonable rate.
One of the best explanations I've heard, and you do a lot of ablations, that oftentimes during an ablation, a patient can be in atrial fibrillation, then spontaneously converts to flutter.
Yes.
And typically you'll burst pace that. What you typically do in your lab?
Yeah, we can do that in our lab pretty easily, actually, and that's the basis of this. Is what we do in the lab is now translated to what a device can do. So it's very physiological, very reasonable.
Question that comes up quite a bit is, if this is converting a patient from an atrial arrhythmia to sinus rhythm, and the patient's not anticoagulated, what type of risk are we looking at?
That's a really important question. I think we have to think about what the guidelines say. And so the guidelines tell us that if they're not anticoagulated, you can cardiovert them within 48 hours of the episode initiation. And so the device actually allows you to program that. And so you can tell the device, if it's greater than 48 hours, don't attempt. Attempt within the 48 hours. And if you want to be more conservative, you can say 24 hours. In many of these patients, you may want to consider anticoagulation anyways.
Yeah. What do you do in your practice? 24 hours or 48?
We do 48 hours in our practice, yeah.
Another question comes in, you've got a lead in a right atrium. Some of these rhythms originate in the left atrium. How can you terminate that?
Yeah, I think it's similar to when you're in VT and you pace them in the right ventricle. You can terminate VT that's coming from the left ventricle. So it can happen. Now sometimes, sure, it's chaotic in the left and organized in the right. In those cases, you may not terminate. But on average, I think there are opportunities to terminate these rhythms.
That may even show up in the data, where the success rate for ATP was about, what, 44%?
Exactly, it did show up, exactly, yeah.
There's concerns about acceleration. Do you accelerate the rhythm into atrial fibrillation?
Yeah, I think, you're already in AFib, now you organize a little bit, there's certainly that possibility, but I think the data really shows that we're reducing the episodes of atrial fibrillation on average, which is kind of what we're seeing clinically as well.
So less episodes in your arm with reactive ATP. I think it's possible that some of that may come from some of the previous overdrive algorithms.
That's right, yeah. So the previous overdrive algorithms, for example, when you tried to pace the atrium a little bit faster than the native rate, unfortunately, occasionally would pace during strange times. There were some issues of undersensing and actually may have promoted atrial fibrillation in certain cases.
Yeah, we believe that appropriate sensing is fundamental to these algorithms as well.
Yeah. Yeah.
You pointed this one out, I think, which is interesting data. I think you said it's tantalizing. There may be a hint at remodeling. So at this point, we have that these episodes may be shortened in duration, but what are the benefits?
Yeah.
If the benefit in the mind is, has it been shown to reduce the risk of stroke or the rate of stroke, or taking patients off anticoagulation, if that hasn't been shown, what are the benefits?
Well, I mean, I think as a physician, I'll tell you the number one benefit is improved symptoms. And I can tell you time and time again, our patients don't feel well in AFib. And if you can reduce the episodes of AFib, they feel better on average. So that's the first one. There's a lot of other benefits. For example, some of these patients do have heart failure. And when they're in AFib, they develop heart failure, they end up in the hospital. So if you can reduce that, that's a significant benefit as well. Patients have less likelihood of having a cardioversion or needing a cardioversion, and that's useful because, again, a cardioversion, they have to get a ride, they get anesthesia, they have a procedure done. So if we're able to not have a cardioversion, that'd be very useful as well. So I do see a lot of benefits for this, and potentially remodeling if that ends up panning out.
What about keeping patients from progressing from paroxysmal to persistent in terms of an ablation?
Yeah, I like that idea too. I mean, this idea that maybe the atrium doesn't remodel as much is helpful, because certainly with ablation, our success rates are higher with paroxysmal patients, and so if we can keep them paroxysmal as long as possible and then do an ablation, our success rates are indeed a little bit higher. So I think that's a useful concept as well.
A few other questions. One comes up, what about the hit on battery longevity with a feature like this?
Yeah, not a significant hit on battery, because it only has to pace episodically. And if somebody's pacing all the time and having this algorithm activate all the time, then you probably need to change strategies.
Okay. Question, can we turn it on at implant?
Don't recommend it. In fact, you shouldn't do that. So basically what we do is we wait for the lead to mature for a period of time, typically 6 weeks, and then after that, in our clinic, the way it happens is the patient comes for a follow-up, and at that first follow-up, these algorithms are typically turned on.
And there's a question about your own practice. Do you turn this on in only patients who have a history of atrial fibrillation, or do you use it proactively?
We use it proactively. I think, we've seen that a lot of the patients, as we pointed out earlier, a lot of these patients will develop atrial fibrillation. So it doesn't really hurt to turn it on. I don't see a real downside to turning it on, to be honest with you. The device is in there. I view it as a freebie. The device is in there. Why not use it?